So we are going to start with an omphalocele case, and we're going to start by just talking about some of the general physiologic principles that I think are underreported in the literature, and then we'll go to management. And I'm going to get some input from Miguel Guelfand on that one. So baby's born with something that looks like that, and we're going to call it a 5.5 centimeter omphalocele with liver in the sac. And compared to any other baby with omphalocele, compared to the routine omphalocele that doesn't have these dimensions, the parent should be consulted that this has a comparable risk of respiratory compromise. There is a greater chance of having a chromosomal anomaly. Time to full feeds will be the same as any other baby with omphalocele. Time to closure will likely be a year or more. And if the echo shows no pulmonary hypertension on day of life 3, there is no risk of subsequent respiratory compromise. And so to talk about that a little bit, we put together a 2-center retrospective study that encompassed 20 years, and we had 97 survivors. And patients who were found to have a giant omphalocele, typically defined as 5 centimeters or greater or liver in the sac. Those patients with the giant omphalocele had a greater time to full feeds, required more TPN. They also had a greater risk of respiratory insufficiency, and they did have a higher incidence of chromosomal anomalies. But interestingly, we typically, at least I was taught in fellowship, think of these as pulmonary hypoplasia as being the main problem, that pulmonary hypertension is a problem in CDH, but pulmonary hypoplasia is the problem when you have an omphalocele. But what we found was that 56 patients of those 97 were identified as having pulmonary hypertension. Now, most of those were diagnosed within the first week of life. But interestingly, we had 5 patients out of those 56 that had no signs of pulmonary hypertension in their first echo within the first 7 days of life. And then they subsequently went on to have pulmonary hypertension later. And this was severe pulmonary hypertension, where 2 of the patients ended up dying, and 1 was on a pulmonary vasodilator for more than a year. And all of these were associated with an episode of sepsis. So what that tells us is that even in the patient who doesn't have signs of respiratory compromise early, sepsis later, and one of them was 52 days after their initial echo, showed no pulmonary hypertension, that a single episode of sepsis put these patients at high risk. So now that we've got, I guess I'll ask Todd or Rod if we see anything in the chat feed on how people answered that question.
Nothing in the chat feed yet. They're still hanging on, still have some questions about contrast and things like that. But I will say the poll results are coming in. Overwhelmingly, people are saying all of the above. 65% of the people who are responding are saying all of the above. And then the next most common is people are saying that you got to talk to these patients, these parents about sepsis.
Yeah. So now what? That's the background of an omphalocele, but how are we going to manage this? And we could paint the sac, and we'll take this exact example. How would you manage that patient right there? Paint the sac, remove the sac and passive reduction, remove the sac, active reduction, keep the sac and active reduction. And the choice I didn't really give would just be definitive closure right now. This is where I'm going to turn to Miguel Guelfand, because there's multiple mechanisms that have been described for keep the sac and active reduction. So that was the answer that we were looking for there, because the time to definitive closure does not have to be more than a year. And with that risk of sepsis, there's the theoretical advantage of the quicker you can get to closure, then the better off you are. So Miguel, do you want to chime in on your technique here that I've got a few pictures of? And this is keeping the sac in place and then doing active reduction.
Yeah, I think the initial picture is in this case was a little bigger than the initial that you showed, but this is a technique that developed by Dr. Abelo from Colombia that we started doing it about 3 years ago, and together we have treated almost 40 patients already, and it's a very easy and very smooth technique. As you see, you have to do a hydrocolloid dressing to do a silo without removing the sac. And in these 40 patients, we get to close 97% of them within 30 days and 92% within 15 days. So actually, we have done very well. All these patients keep in ICU, ventilated and completely paralyzed, but we can get a very high closure in time, almost in 95% of them.
Yeah, I think, Miguel, you presented this at APSA, and I moderated that discussion. That was quite amazing. I don't know, Shawn, what do you think? I've not been able to close every single one of these big ones.
No, likewise. I was impressed that they didn't have more troubles with pulmonary compromise with the active reduction. I think that's the difference. We give up on active reduction when the patients don't tolerate it from a respiratory standpoint and then go to painting. And we've had some recently that are just incredibly labile, that even being in a completely supine position, they have respiratory compromise.
They're stronger in Chile, I guess.
Yeah.
So I'm sorry, can you just explain again? So when you paint first and then put this on, or how long after the baby's born do you apply this?
You asking me?
Yeah, I'll ask you.
Yeah.
No, you just put this, I mean, hours after the baby is born.
Yeah.
You don't paint it at all. Actually, you have to put it hopefully within the first 24 hours, so the sac that doesn't get, very stiff. And the hydrocolloid, it gets the sac very, very smooth, very hydrated. So
Miguel,
then you can start.
You don't get scared that it's not going to, when you put so much pressure on a very thin wall, it's going to burst?
No, actually we have three patients that were born with a ruptured omphalocele that we suture the omphalocele and then put this dressing.
We're not as bold as Miguel. We will sometimes wait a few days, but it still seems to work, Miguel. If if you're afraid, like Todd's saying, that the sac might tear from all the pressure in the first couple of days, like we've certainly waited a couple of days, had some other dressing on, and then once the sac is no longer like paper thin and see-through, then start the duoderm, and seems like it still works.
I know I didn't say it doesn't work, but it gets stiffer. So the beauty of this that the baby has to be stable to start doing the compressions, but usually you can start within 48 hours. About all of these patients are intubated and completely paralyzed during this procedure.
Okay. I'm going to try. We just had a kid born. Wolfgang and I disagreed. I think he's crazy. He wanted to push it in. I thought it was too big. So maybe we'll compromise and do this on Monday. Mark, you want to try it with me on Monday? We'll FaceTime Miguel.
Absolutely.
Okay.
Okay, so now we're going to move on to the definitive closure. You get it all reduced, and now it's time to close the belly. And the question is, should we do a lab procedure at that time since we are in the abdomen, if your closure involves being in the abdomen? And data that we joined with Milwaukee, this was Amy Wagner's project. She wanted to look at the risk of somebody having a volvulus versus an adhesive bowel obstruction after they've had a definitive closure for omphalocele or gastroschisis. And what we found was that there was an increased risk of adhesive bowel obstruction, of course, with gastroschisis, but the risk of midgut volvulus was higher in patients with omphalocele. And that supported the claim that if you're exposing the intestines, then it's worthwhile doing a lab procedure at the time, because these patients have non-rotation or malrotation, and they're not going to have the same adhesions that you have with gastroschisis.
So Shawn, I've never done, I would now, I guess, but I've never done a LADS in any of these patients. But I always, with this slide you're showing, I always have a problem with that slide. The one, it's okay, you don't have to pull it up, but comparing bowel obstruction to midgut volvulus.
Yeah, so it's not.
One is lethal and one is.
No, sorry, they're both just on the same chart, but they're not comparing the two. It's just showing that if you have gastroschisis, you have a much higher risk of bowel obstruction. We all know that, but the risk of midgut volvulus is higher in patients who have omphalocele than with gastroschisis. And so we just don't see a lot of volvulus with gastroschisis, but we do see it with omphalocele. Just simply making the point that, I guess, take it another way. If you have to operate on somebody with gastroschisis, you typically end up making sure you line them up like a latch. You make sure that the colon's on the left, small bowel's on the right, the anterior surface of the mesentery is exposed, as opposed to just tucking it in. And so it's sort of the same boat, that if you have access to the intestine, and that was the soft part about that manuscript, was that we're not saying it's worthwhile to go through the sac if that's not your technique. So the sac is maintained in Miguel's technique. So it wouldn't be worth going after it inside the sac. But if your operation involves exposing the intestines, then it may be worth considering a lab procedure.
So Shawn, when you stuff, do you do a bedside gastroschisis tape closure?
Oh yeah, we do sutureless closure now.
Right.
So we never see it.
Lay anything any kind of way you
Nope.
want.
Exactly. You never get to see it in that circumstance. And then you're hoping that the adhesions take care of it from there.
So another option, I think, what you're coming to, Todd, is to say that this is similar to diaphragmatic hernias. So when you're doing a diaphragmatic hernia repair, you expect them to kind of have a malrotation because the gut's not in the right place. And so how many people would do a LAD procedure concomitant to a diaphragmatic hernia repair? Shawn, do you do those?
Yes and no. So I'm not going to take out the appendix, but I'm going to make darn sure that the small bowel's to the right, the colon's to the left, and the anterior surface of the mesentery is exposed and it's not rolled in. I mean, the risk, the thing that you're looking for is those patients where the cecum and the proximal bowel are just kind of rolled in together, and you can just unroll them like a scroll. And that's the key move that's going to theoretically decrease the distance between the two ends, or increase the distance between the two ends of the jump rope, so that you don't have that risk of doing the full twist.
Right. So it's a judgment thing. So you'll judge, look at it, and you'll see it. So Mac was shaking his head no. Mac, you never do it?
Well, I can't do a LAD procedure through a thoracoscopy approach.
Well, if you're doing thoracoscopy, that's
right.
Right. That's going to be really challenging.
That goes without saying.
Joe Iacono really wants us to pay attention to the terminology we're using and how they're different: malrotation and non-rotation.
Yeah, that's very important.
Fair enough.
Huge difference.
And these patients are all non-rotated.
Yeah.
For the most part.
And also several other people, Ben Nwame, a lot of other people are posting other protocols of reducing. So it's worth looking at. I mean, I guess the point is non-rotation shouldn't have much of a risk of volvulus. So, I think your data says otherwise, Shawn. I mean, you have non-rotated babies getting midgut volvulus.
Yeah, that's true. And I've found that non-rotation does not exclude you from having the possibility of having anatomy that's not favorable, with the narrow base of mesentery and the two ends being fairly close together. It's not universal, but that's what we found, is that it does happen.
Okay, that was awesome.
Saleem's sharing a screen now. Is that right?
Yeah, and I started at the end. So what you have is, and I'll show the images in a second, you have a 36-week gestational age male who's full term, born with a prenatal diagnosis of, it was an abdominal wall defect that the MFMs had a lot of trouble trying to characterize. Is it omphalocele? Is it a gastroschisis? Unclear. After delivery, he's noted to have a very large defect, almost no anterior abdomen at all, with the viscera that includes almost the entire liver, a large amount of intestine, the stomach. There's no visible amnion or any covering of the, and basically what you have to do is put on a gigantic silo, which we used a 10-centimeter silo here, to just cover the viscera and try to figure out what's going on. So there's another image of it. You can see the entire liver's onto the back, the stomach, the colon, everything is there right now. So the question is, how would people in the group classify this defect? Are you dealing with a gastroschisis or are you dealing with an omphalocele? Shawn, what do you think in this situation?
I would take a look at the abdomen.
Oh, here it is. I mean, you saw it.
Where's the defect relative to the cord?
It's right smack dab in the middle. There's a cord just to the upper part of it, or it's unclear. Seems to be on the upper part.
Then I guess the question would be, does it matter? And it would depend on the physiology of the patient at that point. And I'd be more concerned about what the lungs are doing, because your belly status is what it is.
Yeah. So in this case, that's anybody else. So Todd, what would you call it? Are you going to call it a
Yeah, I was going to say just what Shawn said. Now you just have bowel outside of the belly, other than looking for congenital anomalies, which is rare in a large omphalocele. There shouldn't be really any difference between the two babies.
I agree.
Well, the problem what we had is basically in terms of the next management. Yeah, we got the silo on. We have that all done. So we call this a ruptured omphalocele. And the rationale for calling this a ruptured omphalocele was that the defect was very large and the entire liver was out. In a gastroschisis, you don't expect the liver to be out. And when you have almost no abdominal domain, it becomes really challenging to try to do anything in place. So here are your choices. So I think, do you guys, Ray, do you have that in the, Jay, you have that in the global cast part 2?
Yep, we got it.
Okay, so here are the choices. You either leave the silo in place and start squeezing down on that. You can create a separate silastic silo that you sew to either the fascia or the skin. You can create a silo with PTFE mesh or with biologic mesh, which is the next choice, and sew both those to the fascial edges. Or you can do and take a long vacation that you always wanted to and leave it to somebody else. So how many seconds you want to give that, Todd? Like 10?
It takes them, it's a 20-second delay between when you talk and they get it. So let me at least.
Well, let's ask the guys here. Miguel, so you're faced this situation where there simply is nothing to sew. There's no amnion at all. What do you do in that situation?
In this huge whatever gastroschisis or omphalocele that I don't have a place to put the hydrocolloid. We have using the same technique for the last 15 years because I know it's going to be our long run to reduce all things. And the only thing have been okay with us is put a prolene mesh because it stays forever until we can close the case, and we protect that within a plastic bag within the bowel.
So the answers are, the most common answer is leave the silo in place. It's changing every second. A lot of people are saying create a biological mesh silo, which I don't like, to be honest. It adheres to the bowel, but that's, I will tell you one thing. I wonder if any other people have had a problem. When I have a giant, I'm just going to call it abdominal wall defect. I don't need to know
That's fair.
but when I have a giant abdominal wall defect and I put a Bentec silo, a spring-loaded silo, and I push down, the forces go out. And I find that it actually makes your defect much bigger over time. And I used to tease people that would do the old-fashioned sewing, but I actually think in these cases, it may portend a better outcome.
Well, it's good. It's interesting that you brought that up because, when you try to squeeze on that mesh, when people try to squeeze on it, it just popped right out because the defect is so big that nothing holds it in place. So what we did was, we eventually, and there's no right answer in that poll, but it's interesting that most people were choosing the biologic mesh. We used that because we used it as a scaffold. So Todd, you mentioned that it sticks to the bowel. Yeah, it does. And it does create a scaffold, and that's what you want it to do, to allow the skin to epithelialize, which it did. We then did a circumcision, used that skin to kind of also create a graft and put that on. And then the plastic surgeons came and put tissue expanders in, we got flaps, and we managed to finally get coverage. And then we created some domain by before the mesh got incorporated, is we just serially resected it and then just reduced it and get the upper parts of the mesh and stretch the fascia a bit. So now the question becomes, he's 4 years old, you managed to get all that skin coverage, he survived, and now what do you do? Now you've got just a gigantic ventral hernia. It looks like he's about, the guts are about to fall out of his belly every time he walks. So the choices are, you can just do nothing, leave him with a gigantic ventral hernia. You can replace it with a permanent mesh, either PTFE or nylon. You can do a separation of components, closure of the fascia with some mesh if needed, or vacation's always an option.
So,
And I
Saleem,
wanted to, while we wait for the responses, I just wanted to address some of the people in the comments section here. A lot of people posting, like Todd was saying earlier, articles, but now even technique videos. So you can upload a YouTube link here for everyone else to see how other people are closing these giant defects. And then a lot of really great questions here. Some people asking about, hey, what about tissue expanders in this scenario? I know you talked about we're trying to get domain. Is that an option? Some people talking about timing and things like that. And with all of this adding up, a lot of people are still choosing to take that long vacation.
Vacations are
Saleem?
never a bad idea. Never.
Saleem?
Yeah. Yes, Miguel.
I think to get a huge ventral should be the last decision. I think our experience has been completely different from that. We have able to manage this huge omphalocele gastroschisis, and the less of them get a ventral hernia. And even though it's a smaller one, that just leave them to spittle size. We actively treated them with very good results.
Mm-hmm. So you would have closed them in the neonatal period?
No. Well, I will try to do the thing I said. This prolin mesh that I've had this for months without taking out that same mesh, and I have to say 80% of them we can close it within 2 or 3 months.
Mm-hmm. Mm-hmm.
but if you get, the one thing you don't have on there, Saleem, that we've done in Atlanta is it was the tissue expanders. I think Kurt may have mentioned that in the chat.
Yeah.
And have the plastic surgeons come in and put some tissue expanders in before you try to close it, and it gives you some more. It will stretch the fascia and the whole abdominal wall and get it closed.
Mark, you put the tissue expanders inside the belly, so somewhere
inside,
fascia, pelvis or somewhere.
Yeah.
Yeah.
Saleem, it's Eric. We've had a different experience using it primarily subcutaneously. So I think one of the key things, particularly if you anticipate having to do serial procedures, is you need really healthy skin, and particularly the ones that are treated with paint and weight initially don't have very good skin. So we would expand the subcutaneous layer to get really good redundant skin. And then if it's the example that you showed, I think you're going to need to do serial procedures where you're imbricating or excising segments of a biologic mesh or something like that, so that you'll gradually get those rectus margins upwards. The other option I think would be component separation, and I think in an older child that's a possibility.
Yeah, and so and again, remember the vacation. Everybody should remember the vacation. So component separation is what we ended up doing, and so Mark, we thought about putting a expander in, but our plastic folks felt that if you put it in the belly without any domain really, or without anything, you would basically just push all the contents up and out, and that's what their concern was. But I think tissue expanders remain a great idea. We did use tissue expanders in the subcutaneous tissue to create space, but the component separation technique basically involves the use of separating the tissue at the external oblique and just beyond, about 1 centimeter beyond the rectus sheath, which is right here, and then that creates a lot of space. And you do this on both sides. And then, of course, you have to dissect between the external oblique and the transversus and the internal oblique. And then that creates a lot of room. You can also make an incision on top of the rectus sheath, the anterior rectus sheath, to give you another centimeter or so. And remember, this is on both sides. So you can create a lot of room to get space. And in a report from Texas, UT Houston, the group there, Kojin and Rich and Gracie in that group, they reported the use of this in 9 kids, and they use it in every age. You can see from 7 days to about 10 years of age. A majority of them were omphalocele and giant defects, and they were able to close almost every single one of them. They did use some mesh in some cases to help them bridge defects, but they were, again, able to get fascial closure in a vast majority of them, which was pretty good. So again, separation of components technique, which our adult colleagues use all the time, is something to always remember. And they, again, felt that they could use it even in babies where they could get good results. So that was just a little twist on the omphalocele to kind of end that and discussion. Let's see if I can come up.
All right. So that was great. I think so. Between the three of you, have no more cases to present, right?
We don't have Omphalocele, correct?
All right. Do we have more cases?
We have 2 gastroschisis, but we can skip gastroschisis if that gets us back on time.
Let's do this. I have an idea. Shawn and Saleem, can you, without slides, give us the major take-home points that you were going to show with gastroschisis?
Let me see. Let me stop the share. Hold on a second. Okay. So the major take-home points were fairly straightforward. We were going to talk about complex gastroschisis and mention the fact that, and as a plea to everybody, that complex gastroschisis is really a different disease almost to the simple variety of this condition. Everything is worse. The hospital length of stay, the requirement for further operations, their sepsis rates, everything is just worse. So just know about that. We then wanted to kind of address the point of how do you deal with an atresia. So if you're presented with an atresia that you can see right then and there, what would people do? Would people repair it before reducing it? Would people reduce it and then bring it out at some other defined period and then repair it? Or would people create a stoma?
All right, so we're going to do this in 3 minutes. We're going to do gastroschisis. Raise your hands and answer in the chat and tell us.
But Todd, Jay has that poll. You want Jay to just put up that poll?
Sure, Jay can put up the poll, but just to move on with time, who here in the Zoom, in the faculty, if there's not matted bowel, if you can get around and see the anatomy and you see an atresia, who would bring out a stoma? Let's do that. Anyone? Would anyone bring out a stoma? Okay. Would anyone do a primary anastomosis? 1, 2, 3, 4, 5 of you. Would anyone drop it back in and wait six weeks or so? 1, 2, 3, 4, 5, 6. It's divided. Saleem, do we have like data on this? What is the right answer?
It probably depends on what the bowel looks like.
Well, that's important.
That's the thing. We said
we don't have data, but we have a lot of opinions.
Right. For this case, Mark, we're talking about non-matted bowel. So
it looks normal. I'd put it together.
Put it together.
That's a case I have yet to see. I got to be honest with you. To see totally normal bowel that looks good.
Come to Chile.
I've seen pretty normal bowel, but I've never seen
Chile.
normal bowel with an atresia.
That's exactly right, Mark. That's what I'm saying. It's usually hard to tell that there is one.
Southern Hemisphere is great. So
that's fast. So when you see atresia, it usually means matted. The two go hand in hand. Matted bowel atresia.
Usually a bad gastroschisis, yeah.
Okay. Perfect. Any other thoughts about what you do when you see an atresia? All right. Next thing.
Next thing, I think Shawn was going to talk about sutureless repair.
Yeah, we were just going to go through some of the data that came from the Midwest Consortium with the gastroschisis data. That's a project that Jason Frazier was leading. And what we found across the institutions, we had about 70 patients who had been managed with the sutureless closure, most of which were not intubated to put the silo on. And so for those who don't practice it, what the sutureless closure means is you put the silo on, or you just tuck the bowel in and then you put an occlusive dressing on there. Usually you change it at 5 days, and then the next change, it's mostly closed at that point. You can go to simple dressings. But what we found was that there was no difference in time to full feeds, TPN use, or duration of hospital stay, but there were fewer anesthetics, and the patients who were being managed with the sutureless closure got antibiotics less frequently, and they ended up with less infections also. So they had fewer infections and septic events despite having less antibiotics, and that's probably provider specific. But just the same, what we took away from it is that we probably shouldn't be so aggressive with antibiotics after babies are born with gastroschisis, regardless of how we manage them. And if we're going to do sutureless closure, try to avoid an intubation and an anesthetic, and then that becomes the advantage that they have.
All right, let's do some rapid fire comments on that by chat, by comments here.
I want to make one thing, Todd. So in the chat we're having here is Max said that while in Witt's first week in practice, he had a gastroschisis with 4 atresias and needed 4 anastomoses. And Kurt added to that, he then went on vacation.
So Mac has a really good memory, because I hope the patient did well. well.
It was a bumpy road, Britt. It was a bumpy road.
But the anastomoses were okay, weren't they?
So I know, Shawn, there's been a lot of, I know that we've presented through the app and whatever, through social media, many different studies. Robert Baird had a study that showed that Sutureless did better. Then the Stanford group did a study that showed sutured repair did better. Yours kind of shows about the same.
So two different things, sutured versus non-sutured. And that's different from silo versus immediate closure. And so that's where this conversation ends up getting convoluted a little bit. But we had done a randomized trial. We ended up randomizing over 50 patients and found that there was no difference between immediate closure and silo. And the conclusion of that was that this paves the way for sutureless closure, because if we went from silo to sutureless and we never answered the question, does just tucking it all in and closing the defect initially do better? Then we wouldn't go down the sutureless path. But when that was equivalent, we then went down the sutureless path. And then the data that I was just describing is a retrospective comparative between the 11 centers, where some centers were doing sutureless closure and some centers weren't. And so we just compiled it all and threw it together. And you can imagine that what throws a lot of unnecessary heterogeneity into that data is they're also being managed differently. So I think half of the centers have a feeding protocol, half don't. The neonatologists have a huge range of what they're comfortable with. So so that throws up enough background noise that I'm not surprised that we don't see any difference in terms of length of stay or time to full feeds.
And I guess also the thing is, when you're talking about closure, I mean, immediate versus silo, I think your randomized study showed there was really no difference between the two.
Exactly.
When you appropriately select the patient. And what we found in our multi-center study was that when you compare the immediate closure group with those silo closures, which were the majority, that were closed within 5 days, there is really no difference in those two groups. And in fact, the silo closures in that situation did better than the ones that we tried to immediately close in terms of ventilator days and in terms of umbilical hernia and ventral defects. So I think when you talk about silos, it's important to know that when they're taking more than a week or 10 days to close, you're probably talking about a different set of patients. And lumping them into the same group as all silos is probably unfair when you're trying to compare them with immediate closure.
This is great discussion. We have a lot of comments. By the way, I'm gonna threaten the flow here, which is going awesome. We're gonna stop it, but for those of you in the audience, because there's a lot of chatty Cathys here that we love that. We want you to come into the Zoom room. So if you want to come in and share your thoughts instead of just typing and you want to talk, we'll give you the link and you can come join us here in this little fun room over here. So yeah.
Just to tell that we start doing, we could start combining the two techniques. We start doing a sutureless closure. I mean, we take together everything inside the abdomen and it didn't close with any suture, put the, the dressing, and then 2 or 3 days after, we get just one surgery and close it right away, because sometimes it gets a very long time to get this gets closed, 5, 7, maybe sometimes 2 weeks to get it closure. So after 2 or 3 days, the abdomen is completely soft. There's no tension at all. And it's a very easy closure. And then 2 or 3 after days, we have the sutureless. You close it and there's no problem.
So clearly this has a lot of points. I'm going to want you to, let's bring this discussion to the chat, because I think that this is not done. There's a lot of conversation about this. We should probably do another session just on this. But for now,